And without further ado, she's already been introduced, so I'm going to have Paula Ferrada come back up. She's at the Commonwealth Virginia University, and she's in charge of the fellowship program as well as the trauma and surgical ICU there as well. So welcome back to stage, Paula.
Can we go back to the first slide, please? Okay, thank you so much for the opportunity and the privilege to be here today. In the next few minutes, we're going to talk about the importance of international collaboration in surgical education. I have no commercial disclosures, but as we established before, I have a lot of biases, and I am not going to apologize for them. But you will be painfully exposed to those biases as I go along. Let's first talk about the need. There's a huge necessity to understand surgical disease as a preventable disease. According to the World Health Organization, more than 500,000 deaths, maternal deaths, could have been prevented if there was appropriate surgeons that will be able to take care of this bleeding. And that's not even talking about trauma. If we see this chart, we can see that pretty much in every continent, everywhere where there's a need, in low and medium income countries, the projected fatality for 2020 is about 15%. That's too many people dying for something that can be simply taken care of by somebody that can take care of surgical diseases. And then there's several issues in different places. Not every place is the same. Every country, and even in the United States, every underserved area has different issues. There's some places that have lack of human resources. We heard Dr. Rubiano talking about how there was a lack of good trainees in neurosurgery, where there's some places in the world in which you have to actually pay to be a resident. You have to pay to serve the hospital. So therefore, it's really hard to get people to get this type of training if you have to not only sacrifice that time of your life, but actually pay them to be able to train. In some places, there's lack of technology. In some places, there's need for registries. If you don't have a registry and you cannot tell people what your problem is, then you will not have the credibility necessary to advocate for allocation of resources in the places that you need them. And for that advocacy, we also need organizations that actually can reach out of the places of need. And then those of you that were in the morning, you already saw this slide. This is representative of most trauma centers in the United States. There's plenty of human resources. There's an otoscope, an ophthalmoscope. You can put a Vigileo, you can put a Swan, you can do an echo, you can do anything you want. The patient has plenty of resources to help them survive. But that's not the case everywhere. This patient is alone. And this is not okay. There's a lot of things that we're going to talk about that are important in order to bring this patient the service that this patient needs. And then, of course, the answer is always going to be education and collaboration, so we can bring education to the United States to make them understand, not only the United States, but high-income countries, so we can allocate resources better, education to the low and medium-income countries, so we can all work together. But in order to educate, one must be heard, understood, and believed. And believing somebody requires for you to have credibility. Credibility follows capacity and talent. Let's talk about, and these become a little bit more important in the next few slides. Let's talk about education in the United States. Most of program directors are familiar with this study published by Dr. Matter. They survey fellowship directors from laparoscopic fellowships, and they discovered that 38% of the trainees demonstrated lack of patient ownership. 30% could not independently perform a laparoscopic cholecystectomy. 24% were unable to recognize early signs of complications. 66% were deemed unable to operate for 30 minutes unsupervised. And I know that right now it seems like just numbers, but I was trained, I grew up in a house full of healthcare providers. And I was taught and I was raised to think, I'm gonna serve that patient like I would want my family member to be served. And I think 66% of not being able to do it on your own is unacceptable for anybody that is in my family. And why is this? Many reasons. Some of it is the 80-hour restriction. Some of it is that we're now measured for RVUs, and when you're teaching, you're taking a little bit more time, and that more time that you're spending in teaching is less time that you're spending in finishing the case so you can get the other one so you can bill for another case. These are all ethical dilemmas that hinder the exposure for trainees in our country. And then this is not only inclusive of laparoscopic fellowships, but this extends above and beyond. The issue with trauma and acute care surgery is when we have a patient that is sick, you need somebody that is that has really good training and that knows how to take care of that patient, because that patient is not going to take a second hit. That patient is physiologically not great, it's not like an elective patient, and the anatomy is distorted, so you want somebody that really knows what they're doing. This was presented last year at the AAST, showing that in acute care surgery, there's also lack of volume in head and neck cases and in pediatric experience. So the lack of experience, lack of volume, and issues with education involve us all. Surgical disease is a public health issue. This was published after the presentation of Paul Farmer in the American College of Surgeons. Centralization of care, it happens in the United States, it happens in Europe, it happens in high-income countries as well. There's a centers that knows how to do it all, they keep the experts, and so everybody wants to go there, and there's not enough people to help and do surgery in rural places. It's worse when you're in a low-income country, because not only the resources, the financial resources are gonna follow those people that wanna be in the places of, that are centralized. There's lack of resources, there's lack of awareness, and if there's lack of awareness, then you cannot convince anybody else that you have a problem. The lack of government involvement, secondary to that lack of awareness, there's lack of operators, there's lack of access to resources. And if we want to be part of the solution, then we need to start thinking to ourselves, not as this map. We need to recognize that we all have opportunities, and that we all have strengths. And sometimes America might not be the #1. We need to have an accurate self-image in order for us to be able to help each other. And how do we help each other? So by recognizing the good things that we can give to the other countries, by recognizing the principle of reciprocity. If we're going to improve our education and by sending somebody abroad, then perhaps we need to think about ways in which that place that is going to receive that trainee is going to have something back. And I'm not talking necessarily about money, and I know it's challenging to bring him here to operate, but there's many other ways that you can give back. There's ethical considerations. If it's not okay in the United States to have an untrained medical student perform a C-section, then it should not be okay for that medical student to go perform a C-section anywhere else. Because that same patient deserves better and deserves the same care here and everywhere in the world. What is in for the United States? Well, you know, you will expose your trainee to other culture and other healthcare system. They will see problems that are not in the United States. Every country has the different prevalence of disease. It gives you an opportunity for increased clinical responsibility, and that hopefully we'd improve the things that we saw in that survey: clinical responsibility and ownership of your patient. And since you have a lot more volume, then it will make you a better technician, and hopefully it will make you appreciate the United States system and know how many great things we have in the United States and how much of a privilege it is to be able to work in a place where you can just bring them to a CT scan and in 30 seconds have an answer. It's not like that in some other places. And this, if we train people better, is going to have a long-term impact on healthcare. And what is in for the other countries, and this is the opportunity where we could create these initiatives to help each other. If we have the trainee, instead of going to a place where they're going to compete with cases for people that are paying for to get trained, but have that trainee going in places where they're needed, rural places where they actually need operators, and have that trainee, instead of saying, I know what to do, let me show you the way, instead of saying that, saying, let me see what you have and how can, with your system, help you get things better with your resources. So that person becomes part of the team and actually helps with the structure rather than disrupting the structure. We can promote international collaborative research projects. This is a great thing to do for low-income countries, because low-income countries are focused on providing for service and they don't have maybe time or resources to allocate for research. So writing stuff together and help them get exposure is a great way of giving back. And in that, also helping them develop the registries that we were talking about, or we have been talking about all afternoon. We can help them participate in international conferences like this one. This is great. Be able to enhance education everywhere so we all can speak the same language. And I'm not talking only about English or Spanish or Portuguese. I'm talking about the language of evidence-based medicine. So we can talk, we can say the same things, we can understand each other. And in trauma, this is of key importance. In many developed countries, there's lack of volume in trauma because there's too many good things, right? There's CT scanners, there's REVOA, there's interventional radiology, so there's less surgery to be done. Therefore, it decreases exposure for our surgeons to be able to perform difficult procedures. If we give them that exposure, that will make them better physicians and better technicians, and it will improve medical care at home. And this is where we have to be crafty and have the people that have the monetary resources involved, because in many cases the only wall, the only barrier to create these programs is money. But at the end, preventing deaths is not only is our mission and what we're supposed to care about from healthcare providers, but it will save us money. Trauma is not going away. It doesn't matter how many good trauma prevention programs we have. There's always going to be military operations. There's always going to be disasters, natural disasters and earthquakes. And unfortunately, sometimes those earthquakes are going to happen in the most underdeveloped countries with the least amount of resources. And I put this slide because I lived in Colombia, South America, when we had a lot of violence. But by the events of last week, we know that this violence is not unique to South America. Trauma is not going anywhere. So then we might as well prepare ourselves to have good providers that can save lives. And the only way that we do that is collaborating with each other and helping each other. The fact that we don't see those deaths in South America or in other places of the world, that doesn't mean that they don't exist. Together we can change the world. I know this sounds very cliche, but I truly believe this. I think that together we can make a better place if we can help each other and understand each other and speak the same language to each other in improving education. Conclusions: trauma is not going away. Education is necessary for improving patient outcome in the United States and everywhere. Collaboration is key, and there are opportunities to collaborate. I think moving forward, what is necessary is to find a structure in which these opportunities can be developed. So it's not a one-time opportunity for learning, but a more linear experience in which we provide the patient not only with technical care, but actually also follow-up, which is also important for our trainees. I appreciate your time. This is my email if anybody wants to contact me. Thank you.
Thank you, Paula, for the excellent talk. I think you mentioned key points, and since we received some questions for the audience, it will be important to know if you have any thoughts regarding what will be the key aspects of the curriculum to take into account for this kind of exchanges and new ideas about how to take international collaboration for surgical education.
So the curriculum, I think, is dependent of the needs for each place and each trainee. Like, for example, the curriculum will be a lot different for, in your case, that you're training neurosurgeons, which is a need in Africa and a need in many places in South America, versus if you're training acute care surgeons. And so it depends of the need of the country and of the trainee. And then, but you're right, there's necessary structure creation and development of curriculums as well as supervision for those trainees.
Question?
Oh, I don't think that's on. I'm not sure how to, oh yeah, it is on. I just want to play devil's advocate for 1 minute. I spent 5 years in Africa, both from a research and a clinical perspective as a surgeon. And this has been studied quite extensively. And I just wanted to challenge the model that you've suggested, because sending our trainees, I think, inevitably breeds a paternalistic model, especially if you're sending our trainees to help licensed surgeons in these rural areas. And arguably, these rural surgeons are so exhausted that the minute anyone comes in, they take a break, because they have to, because they're so overworked and they're so under-resourced, that the trainees do end up doing splenectomies on their own and doing C-sections on their own, and they come back with these war stories of how amazing it was and everything else. And I do think that us inflicted on them model has been shown to not work.
I agree.
And that, you know, the cost of their plane ticket could be a year's salary in Uganda for a new trainee, a local trainee, who could then train under their system, stay there, and provide for the people. So I think there's a lot of momentum right now in both American and Canadian universities to have these global health initiatives, because it's demanded by our students. But really, if you look at the outcomes, it's only benefiting us.
So I agree with the point of, if I miscommunicated in any form, I apologize. I do not think we should go there and tell them this is how it is and I'm going to impart this on you. I think is when we go training people in Latin America, let's say in my case in ultrasound, the idea is to train trainers so they could stay with their resources and create better system for them. And you're right, some places like Operation Giving Back is focusing on going to rural places and help, and the system is not perfect, and it's going to take a lot of tweaking. I was trying to find, I guess, the pros for the United States of creating these programs, not only because our students think it's so cool to go abroad, but to actually fulfill a need. I agree that there needs to be better supervision, and there needs to be a structure. And I was trying to point out that it still does not exist. But I think you and I are on the same page.
Any other questions? Okay.
Thank you.